So it is, truly my honor and joy to introduce Dr. Ebony Boyce Carter. She is the Associate Professor and Director of the Division of Maternal Fetal Medicine at the University of North Carolina at Chapel Hill, and a national leader in reproductive health and equity. Her groundbreaking research focuses on innovative models like group prenatal care to address inequities in maternal health, work that is deeply rooted in community partnership and funded by the NIH, the Robert Wood Johnson Foundation, and the American Diabetes Association. She's also the Associate Editor for Equity at the Green Journal, an ABOG Health Policy Fellow and Principal Investigator of EleVATing Voices, Addressing Depression, Toxic Stress, and Equity in Group Prenatal Care, Women's Health Collaborative. It is an ambitious, community-driven initiative to transform prenatal care. Now I could go on and on more about her impressive credentials, which include Stanford, Michigan, Duke, Harvard, which is where I met her, WashU, and now UNC. But what I really want to share is a Dr. Ebony Boyce Carter that I have known and admired since 2007. So, Ebony, are you 2 year? I can't remember. 1 year? No, it felt like so much more. Okay, fine. So I met, so Ebony and I, we were residents together at the Brigham and Women's Hospital Mass General Integrated Program. And I remember it was one of my first calls on night on labor and delivery at the Brigham. I was an intern. I don't know if you remember this, she probably does. And we were going in and round, during rounds, I was the intern. So I was leading the rounds. And I would go in there and I was all eager, a little nervous, go in there and say, "Hi, my name is Andrea. I'm your intern. This is what we're going to do." I think I did it like for 2 patient rooms. And then Ebony quietly took me to the side and she was like, "Andrea, you're Dr. Jackson. Where's your white coat?" Like she just like maybe stand up a little bit straighter. That moment, it stayed with me. She reminded me that what we do is sacred, that our presence matters, and that our patients, especially those that are marginalized, deserve our full, confident selves. Ebony role modeled for me what it means to lead with clarity, compassion, and an unwavering commitment to health equity. She showed me long before I had the language for it how to serve with purpose inside broken systems and how to do so while holding on to your integrity and your joy. She is brilliant. She is brave. She is deeply principled. And on top of that, she is funny. She has this laugh that fills the room. And even if you don't know what she's laughing about, you find yourself laughing too, just to be near her light. So please join me in welcoming my colleague, my mentor, my friend, Dr. Ebony Boyce Carter.
Good morning, everyone, and thank you so much for having me here. When I got the invitation to essentially travel 12 hours out of 24 hours to speak for 2 hours to the West Coast, normally I would have been like, nope. But for Dr. Andrea Jackson, the answer is always going to be yes. And, I think that when you do residency with someone, you know them to their core, right? Like the strengths, the weaknesses, everything. And this is a picture from my wedding. And do you see who is here? And one of the messages, I have pearls throughout this entire talk. It is a talk about work, but it's also just a talk about life. And so this is one of the pearls, which is take care of each other. I will love you forever, right? After what we have been through. And some of my other residency classmates are here too. So I don't know if Dr. Mocklin is online, but this is from the first day of our intern year. We're getting our fit testing. And then this is a picture of her. We went to the residency graduation dinner of the class ahead of us. So we started residency the next day. So this is our very first day, or I guess the night before our first day of intern year. But take care of each other, because the people that you are training with now will come back time and time again at the highs and the lows of your career and be there. And if you have been good to each other, right, that is actually a really good thing. So as we get into the talk, I have no financial disclosures, but I do want to share that this is not my work. This is not Ebony's work. This is the work of lots of amazing organizations from across the state of Missouri. Community collaborators, these are patients turned partners who have been very instrumental in this work. my co-principal investigator, Shannon Lenz, who is a psychologist at WashU, and then our program staff. So this is a brief outline of what we're going to talk about today. And I don't have a lot of time, but I couldn't go forward in this talk without speaking about the elephant in the room. I've given this talk a couple of times since January. And each time I thought, should I change the title? Right? Which doesn't feel very good. There's an elephant in the room, and I want to spend just a few moments talking about that elephant in the room. So in early February, so EleVATE is an R01 that is ongoing. It is still ongoing, thank God. But I was talking to my mentor about what do I do? Like, how do I manage this time? And he coined a term that I love, that I have used so many times. And he said, Ebony, we are not going to engage in anticipatory obedience. And I had never heard that before, but the message that he gave me that day, that is the message that I'm going to give to all of you, is keep doing good work, keep writing, and keep submitting your work. So a lot of people in this time are going to give up. They're going to go home, say it's not worth it. I mean, I actually honestly had that thought myself. Like, can I still do the work that I do during this time? You know, maybe I should just put my energy elsewhere. And the fact of the matter is, and he raised this point, I think it's true, somebody's still going to get funded. And a lot of people are going to take themselves out of the race before they even tried and started. So this actually might be one of the best times ever to get funded, because people are just going to give up before they even tried. Keep writing, keep submitting, you keep doing the good work that you had already started. And one of the things that I have often said in the EleVATE Collaborative, I'm going to share more of our work today, is that if you improve outcomes for those among us who have the worst outcomes, then you will improve outcomes for everyone. That is true. So I was writing an R01 in January. It was all about racism and racism and reproductive health. And I was submitting it for a February 10th deadline. And then I was like, this is not getting funded. And I mourned that for a little bit. And then I thought about it, and I remembered that phrase. So even though I was focusing on a particular part of the story, the fact of the matter is this intervention was going to improve outcomes for everyone. And so my mom used to read me this book, The Giving Tree. Have you all heard this book? And I was the little boy. My mom was the tree who just gave and gave and gave. And you could tell that story from the perspective of the tree or from the little boy. It's the same story. So I challenge you to think about, in the stories that you are telling and the stories that you are writing, what is the vantage point? Because at first I was like, I'm not changing my grant. I'm not changing a single thing. I'm going to stay true to what I was doing. And it would have died. I wrote the same story from a slightly different vantage point. The aims changed, but the work, the good work that is there, it is identical to what would have happened before, right? With a slightly different vantage point that still can answer all of those same questions. So I'm saying this to encourage you to think creatively about how you continue to do good work. So carefully write your story in a way that is true to your values, that continues to advance important work. What am I missing? Oh, yeah, it's the retelling of the story, yes. And then does not deplete you, because the journey ahead is yet long, right? So you have to stay recharged and taking care of yourself in the process. So my parting words to you, and how do we get through these times? Remember that the chaos, the confusion, the anticipatory obedience, that's the point. You know, like the way that you're feeling, that is the point. So stay focused, keep doing good work, even in the face of all of this chaos and confusion, and just continuing to do the work. The fact that we are celebrating Black Maternal Health Week is a powerful act of resistance. All right, so I'm going to go back to my outline. And my gift to you today are going to be some pearls that I've learned along the journey that I'll give you with this. So I'm in a story mode. Like, you guys are gonna know my whole life by the time this is over. So I gave a version of this talk several months ago at Duke University Medical School. This is a picture of me from medical school with my friend Erica. This is the amphitheater where we did our classes. And so picture this, 20 years later, I'm back in that same amphitheater giving an endowed lecture. I'm like, if my mom had been there, she would have been like, you know, bragging to everybody who's there. So, oh goodness, I had on the same outfit. And this is Erica, who's a hand surgeon at Duke, and she was standing in the back of the room. So as I'm giving the lecture, I look up and I see Erica. And as I was preparing for this lecture, I thought about med school orientation, and everybody was filing out of the same room for an event. And my mom pulled me aside and she said, Ebby, Your dad and I have done everything in our power to raise you right. Please don't come here and become a physician and in the process forget who you are or whose you are or where you came from. And I had forgotten that story for 20 years until I was preparing this lecture. And what my mom was saying is don't get so caught up in the outcome of being a physician that in the process you forget your values. So this is a picture of my mom from med school graduation, and she had passed away by the time I gave this lecture, because otherwise she would have been in the front row bragging. But the point that she was trying to stress to me that day is a point that I want to give you all today. Process is important. In some ways, process might be more important than the outcome, and you need to honor the process. And so in a lot of scientific talks, it's all about outcomes. Like we love to throw up all the charts of our outcomes. That is not this talk. I'm going to talk to you about the process. So I'm going to tell you a story, and this story, you have to go back. This story happens in the summer of 2016 in St. Louis, Missouri, where I practiced and lived until just about 18 months ago. And this is a heat map of the St. Louis region. And here along the east, you see the Mississippi River. And the numbers are the community partners that I'm going to talk about today. So I, until very recently, practiced right here at number 2 Barnes Jewish Hospital. And this is a heat map of the preterm birth rate in the St. Louis region. And, you know, as you get to red, these are preterm birth rates that are approaching 20%, completely ridiculous. And then as you get to yellow, these are, you know, 3-4% preterm birth rates. So if you look just a mile to my north, you see some of the worst preterm birth rates in the entire world. You look 1 mile to my west, you see some of the best preterm birth rates in the entire world. Who do you think lived to my north? Who do you think lived to my west? And even if you know nothing about the city of St. Louis, I am sure that you can answer that question with 100% accuracy. And therein lies the problem. And that was our situation in 2016. So Melissa Tapey, who was one of the OBGYNs I worked with, also happened to be the chief medical officer of the largest federally qualified community health center in St. Louis, pulled all of us in the community who were doing group prenatal care together and said, y'all, we can't keep doing the same thing the same way and expect a different result. What can we do within our power to change things in our community? So at that first meeting in the basement of Affinity Biddle, the biggest of her community health centers in downtown St. Louis, we agreed on a few things right away. That we were going to be transdisciplinary, we were going to be cross-institutional. We had not historically played nicely in the sandbox. We competed for patients, there was lots of competition. We had to get over that if we were going to do something different. That we wanted to address these reproductive health inequities in our community, and that patients needed to be part of the work. So literally, that was the only meeting we have ever had that did not have patients at the table. This is a picture of the people of the EleVATing Collaborative. Here you see me with my husband and our 3 little girls. And I put this picture here as a reminder that the story I'm telling you, these are real people. These are not statistics, these are numbers, these are real people who have come together to do this work. So there were several areas of disagreement at that meeting. So one was the role of research. In 2016, I am a brand new assistant professor on the tenure track, wanting to do research. And research was a bad name because researchers from WashU and St. Louis University had historically come into our communities, extracted all of the value that they needed. As soon as the money was gone, so were they, never to return to give back any of the wisdom and knowledge that they had learned. And so people were like, no, we're not doing research. We are not engaging in that. And I ultimately argued that if we came up with something really special, but we didn't figure out how to systematically tell that story, then the work would die with us. So we didn't do research in those early days. We did program evaluation. The next thing is, what does accountability to community voice look like? So if you invite people to the table, you need to listen to them. And so what does that relationship look like? And then how do we address the root causes and the policies that were impacting the reproductive health inequities we were seeing? So I adapted this picture from Dr. Joy Greer-Perry. And the first time I saw this, I was like, this makes perfect sense. So do you all do social determinants of health screening here? Okay, so lots of people are starting to do it. And we tend to start there, like at the social drivers of health. But is that where it starts? So we know that the social drivers of health lead to psychosocial stress, these disparities in the distribution of disease, but we need to actually go a layer deeper than that. Why does that happen? There are power and wealth imbalances. And let's go a little deeper into root causes. Institutional racism, class oppression, gender discrimination and exploitation. And if we don't deal with these root causes, If you start way up at the social determinants of health, will you ever fundamentally change things? One of the other areas of agreement in that early meeting was the problem we were facing with mental health. So we were screening everybody for EPDS, and lots of people were screening positive, probably the majority. And then what? In St. Louis in 2016, especially if you were poor, there were no social workers, there were no psychologists, there were no psychiatrists. So people screen positive, and then what do you do with it? And so we wanted to figure out what was in our power, because the mental and the physical are inextricably linked. If we didn't deal with that, then we were also going to miss the mark. So in terms of our power, I told you everyone she invited was a group prenatal care provider. Do you all do centering pregnancy here? Okay, so everybody's familiar. I'm not going to go back through it, but I love group care as a form of care, but that's not why I actually got into it. The reason I got into it was this paper that was published by Jeanette Ikovics in 2007. They randomized about 1,000 patients to group or individual care, and they found that the patients randomized to group had a 33% risk reduction in preterm birth. This is back in the days when we believed Mies, right? So this is the same kind of risk reduction we thought we were getting with 17-OHP. But if you looked at the subgroup of Black patients, there was a 41% risk reduction. The disparity went away. And it was the first paper I had ever seen where that happened. And that's why I got interested in this as an intervention. So this is one of my pearls to the early career folks in the room. When I arrived at Barnes Jewish Hospital in 2013, they had already been doing group care for teens for 15 years. And so I was like, well, is it working? Like, what's happening here? So I did a retrospective cohort study. A retrospective cohort study, trainees, is your best friend, especially if you have a faculty member who has a nice, clean database that you can use, because they're kind of a quick, dirty, easy thing that you can do within your time frame as a trainee. So I looked at our prior experience at Barnes and found that patients who have been in our group program were doing significantly better. But there are problems with observational trials, right? They're prone to bias. You can't totally control for the differences that are there. So this is my next favorite, this probably is my top favorite research design, is a meta-analysis where you take all of the things that have been done before and you look at them and try to come up with, you're now potentially powered. You have all these tiny studies, now you put them all together and you're powered to see real differences. And so I wanted to look and see, for the group care studies, is there a difference? Like, is it true that it reduces the risk of preterm birth? And there were people in the field that I would reach out to. They never replied to me. I was a nobody. I published this paper, and then suddenly I'm like an expert in group prenatal care. Metas are wonderful because it establishes the track record. They're highly cited. So, and they're free. All you need is your time and the skill to be able to do it. So trainees, learn how to do a meta-analysis if you want to put a study design in your tool belt. So you all are lucky I'm short on time, because otherwise I'd be asking you to interpret this forest plot for me. But long story short, I found that when you looked at the observational studies or the randomized studies, and then whether you pulled them together, there was no difference. There was no difference in preterm birth rate. And it was quite disappointing. I got hate mail about this paper, like, how dare you disparage this wonderful form of care? But we did a subgroup analysis of the high quality studies that actually separated the patients out by race, and found that among high quality studies, there was a 45% risk reduction among Black patients who got group prenatal care. So my working hypothesis is that group care is fun, right? Like, if you do it, you're going to enjoy doing it. But if you are those patients living to my west, and you participate in group care, is it going to move the needle for you? No, you already had a 3% preterm birth rate. You're good. If you're the patients moving to living to my north, or a patient who has diabetes or some other high risk condition who are much higher risk for a bad outcome, isn't going to move the needle for you? Yeah, I think probably. So one of the other things that we did as a collaborative is figured out, what is our North Star? What do we want to accomplish during our time together? And I feel like this has been so key. And so the things we said we wanted to do were reduce the Black infant and maternal mortality rate in our community. We wanted to enhance the reimbursements for group care. I don't know, for any of you who have been involved, it's hard. It takes a lot of time. It's expensive. The logistics are difficult. So if you don't incentivize people to do something that's harder, I heard Emily Miller give us talk at SMFM last year, and she said, my job as a health services researcher is to make the right thing to do the easy thing to do. That's the way we should be thinking about things. So if we don't pay people for this extra time, they're not going to do it. And then we wanted to make sure that everything was in the public domain. The populations we wanted to reach were in low resource settings. So We don't want to come up with something cool and then charge you an arm and a leg for it. We wanted everything to be free and in the public domain. And I have pictures throughout. We do booster trainings with all of our EleVATE facilitators. And so this is a picture of our booster training in the summer of 2023. So we also wanted to focus at multiple levels. We often focus on the patients and say, and this, I'm guilty of this too. When I first started doing group care, I thought it was working because we're giving them more time and attention and support and more education. The patients are not the problem. It's us, it's the clinicians, it's the health systems in which we work. So if we just always focus on the patient as the recipient of the intervention, I will also argue we'll miss the mark. So we also work with healthcare teams and doing intensive training with healthcare teams, because I told you about the elephant in the room in this time. The elephant in the room in 2016 is almost all of the clinicians are white. Almost all of the patients are Black. And we normally just ignore that fact, but we wanted to deal with our stuff in real time before we went to patients. And then also healthcare systems. So how do we hold healthcare systems accountable to be a part of the change that we want to see? So in terms of process, in 2016, this is shortly after the murder of Michael Brown in Ferguson, Missouri, which was just 8 miles north of where I was practicing at the time. And in response to that horrific time in St. Louis's history, the Ferguson Commission was formed by, ironically, the governor of Missouri to try to really look and figure out what is our path forward as a city? Like, what is our path forward in terms of racial reconciliation? So I have a QR code. The Ferguson Commission did some amazing work, and they really gave a blueprint for how do you go forward with systems change in a really inclusive way. So the commission report talks about, the checklist for catalyzing change is preparing for the work. So building your inclusive team. What are your core values? What are your principles? And then what are your expectations of each other? You want to engage with community and listen, convene, catalyze, think systemically, right? Think big, not just in your own little corner. So acknowledge the role of race, prioritize policy changes, and then tell the story of the work, which is what I'm doing with all of you today. We talked about trusting that the community has the best answers to the problems that are affecting it, asking the question, and then if you're going to ask it, you better act on it and be accountable to it. We used a racial equity lens for all of our work together. So whenever we would come up with a policy or a plan, we would say, who does this recommendation benefit? How are different racial and ethnic groups affected? And what, or more importantly, who is missing from this discussion so that racial and ethnic disparities can be eliminated? So I love this quote. It's from Reverend Starsky Wilson, who was one of the co-chairs of the Ferguson Commission and now is the president and CEO of the Children's Defense Fund. So Reverend Wilson says, programs are short-term interventions that create temporary improvements in the wake of challenges. Policies, on the other hand, are covenants we collectively choose to live by as articulated in legislation and regulation. They inform our socially accepted mores and ethics. So we were in the process of creating a really cool intervention. That's cute. But if you create an intervention and you don't think about the policies that are going to support it and sustain it, then the intervention is likely going to die as soon as you move on away from it. So we really wanted to be systematic from a policy standpoint from the beginning. So let me tell you what we did. We divided into 3 teams. There was a curriculum team, and we took the entire group prenatal care curriculum that all of us had used, and we blew it up. And over the course of a year, a transdisciplinary team of patients, OBs, midwives, nurses, mental health professionals met together to create a curriculum that essentially was by and for Black patients. The other really cool thing about that curriculum is we decided if the social workers and the psychologists and psychiatrists weren't going to come to us, we were going to create that capacity ourselves. So we trained OBs and midwives to be mental health extenders. And essentially, if you just did the activities that were part of the curriculum, it was evidence-based behavioral health techniques like mindfulness, cognitive behavioral therapy. So it's one-stop shopping. You come get your prenatal care needs met, you also get your behavioral health needs met, and anything we couldn't handle in that group space then got referred out. But 90% was able to be dealt with in the group space. We had an evaluation team. That was mine. So that was the team that tried to systematically look and say, is this working? How is it working? And then a steering committee. Our steering committee still meets every other month. And so people will be like, hey, Ebony, I want EleVATE too. And I'm like, okay, I'll take it to the steering committee. So this is not about any one person. The steering committee sets the path forward of what we're going to do next. This is a picture of our training plan, and it's meant to kind of represent the tip of an iceberg. So all of the practices and clinics kind of had their own cultural competency training or whatever they were doing. We didn't touch that. All of our sites get a 2-hour trauma-informed care training every single year. And I have done several trauma-informed care trainings at this point, but my favorite one was the first one I ever did. And the facilitator said, when a patient comes in cussing and fussing and throwing stuff, and you want to be like, what's wrong with you? Pause in your head and silently think, what happened to you? Mm-hmm. Because just like I didn't wake up trying to be racist today, the patient didn't wake up wanting to act crazy today. Something happened at some point in that patient's life where their power was taken away. And what you're seeing is the manifestation of that. And you don't even have to know what the event was, but just pausing in your head is going to help you meet them with empathy and not like, why are you yelling at me? I didn't do anything to you. So trauma-informed care is powerful. And all of our front-facing staff, so from the front desk staff, phlebotomists, sonographers, everybody at all of our sites gets trauma-informed care training every year. And the other interesting thing is we were in Kansas City in October doing a training, and one of the nurses came up who had done the training the year before, and she said, I always thought that this applied to patients, but when you all did the training, I realized I had trauma in my own life. She was in a relationship with her husband was abusing her essentially. And she was like, it wasn't until hearing those principles that I'm no longer in that situation. And it really started with this. So I think the trainings are powerful in multiple ways. And the best part, guess who does our trainings now? Our patients turn partners. So our patients used to get invited to come share their stories. And at some point they were like, no, we're not sharing our stories anymore. We go in, people are like, oh, so sad. And they keep going on about their business. Well, now when they teach trauma-informed care trainings to the people who are taking care of them, they share their stories, but from a position of power, and something is going to be done about it. All of our clinicians also do the Crossroads anti-racism training. When you do these trainings and they're poorly done, they can actually cause more harm. And Crossroads actually does a very well done training. And then we do 16 hours of group care facilitation and behavioral health. So when you're facilitating a group, if you've done it well, you've had little to say. The wisdom, the knowledge, and the power is coming from the group. And then we did this behavioral health training. And the first few that we did, people hated it. They were like, I'm not a psychologist. Why do I have to do this? I don't, and people did not like that part. So now do you know what we do? It's just all integrated in one. We just don't call it behavioral health training. We do exactly the same thing, just integrated with everything. And people are just as happy as they want to be. So, and I think that's how it should be, right? Behavioral health, like it all goes together. And then we do the intervention. And I would argue that if you take care of people every other week for 2 hours for their entire pregnancy, you get to know their partner and their mom and their kid. The way that you show up to care for them is very different. And I think that you can't have that experience and not try to advocate for systems and policy changes. And this is a picture of a few of our trauma-informed care trainings across the state of Missouri with our patients turned partners leading these trainings. So another thing I want to share with you is that co-creation results in a better product than you'd ever come up with on your own, even though it's messy as I don't know what. So our meetings are messy. When the researchers come in and they sit in on our meetings every week, they're so annoyed because it is not a typical research meeting. Community engaged work is messy, but it is so beautiful because I would have never thought to have the patients turn partners do trauma-informed care training. You get a much better result when you actually listen and engage with people from diverse perspectives. And this is our EleVATing team, like all of our facilitators at Affinity, which is that largest community health center in St. Louis I told you about. So the other thing is these are some of our patients turned partners and their families. And one of the really cool things is they said, one of the things that you said early on is that we have the most important voice at the table. And some of them have not finished high school. And here they are at this table with all these MDs, PhDs, people with all of these degrees. There's this power imbalance inherently. And, she basically said, I'm in this room and all these people are so educated, but you said that I had the most important voice at the table. And then you treated me like I had the most important voice at the table. And I don't know if anybody's ever heard that some of the EleVATing moms speak. They are amazing. And I think part of it is you have to be very intentional about the power dynamics from the beginning and flattening the hierarchy. So I was saying to you to go in and introduce yourself as Dr. Jackson, because as a young Black woman, nobody was going to give you the respect. You needed that white coat, you needed the title. And here I'm saying the opposite. They don't call me Dr. Carter, right? I'm Ebony. And we have a relationship and a friendship, like the hierarchy is gone. So use hierarchy when you need to. If we ask our community partners a question, we should make every effort for the answer to be yes. And this is what Kelly, our program manager. So we would ask a question, the community partners would say what they thought and be like, oh no, we can't do it that way. We've never done it that way. This is about flexing new muscles and trying new things. And we try for the answer to be yes. So I told you it's a process talk, but I'll give you all some outcomes too. This is a paper we published about our pilot work. And so we did a pilot study at 3 sites in St. Louis, and patients were either in traditional prenatal care or EleVATE or kind of centering pregnancy, which some of the sites were doing. And then we followed them out, and this was not powered to see a difference in outcomes. This was just like feasibility, proof of concept. Can we do this kind of right after we finished doing the curriculum? So imagine my surprise when in the individual care group, 18% of the patients had a preterm birth. So that's in line with what we were seeing in our community. And then we looked at the patients who were in EleVATE. Not a single patient in EleVATE had a preterm birth. And this was not a randomized control trial. I can tell you all kinds of issues with the research methodology, but it suggested that maybe there's a there in terms of what we were doing. In terms of relationship, I recently transitioned to UNC Chapel Hill. And what do you do when you're a community engaged researcher? And I had lived in St. Louis for a decade. This was my community, and I go to a new place. And so I started really thinking, what were some of the lessons learned with EleVATE? Because we didn't have some grand plan. Like we just did kind of what felt right as we were going. And now I'm looking back at the last decade. How would I go about this if I was being more intentional? And one of the key points that I think people miss a lot in community engaged research is that we had a trusted broker. WashU was not a trusted broker. So I'm a WashU employee, even though my personal identity as a black woman, when I went in the room in the community, I was the man. My identity as a WashU physician, like basically almost negated my identity as a black woman. And so the St. Louis Integrated Health Network is the safety net organization of St. Louis healthcare providers. So all of the federally qualified community health centers, the academic centers, all belong to the IHN, and the IHN is revered and respected. And so IHN was the convening authority for EleVATE, all of our programmatic grants. So we did nothing but programmatic grants for the first 4 years. They all went to the IHN. This is Nia Plump, who's our EleVATE program manager, and Kelly McKay, who was our program manager and got promoted within the organization. But Kelly and Nia keep us honest. They're like, where's the money going? Like, why is all the money going to WashU? So whenever it makes sense, the money and the power stay in the community with IHN. And the only time that the money comes to the academic center is we're applying for a PCORI or an NIH grant, where just because of the mechanism of the necessity of the mechanism, we have to do it. So the translator, the trusted broker, keeps relationship first. If you're asking for a community partnership for the first time when the RFA comes available for funding, you are too late. Like, relationship is really important. We are there whether the money is there or not. The interactions transcend the ask. The other thing is Kelly went on maternity leave when we were applying for a really big grant. And I thought I was a good community engaged researcher. And then when she was gone, I realized not as much. When we would go out and speak, I didn't know she was meeting with our community partners 3-4 times before I even was invited into the room, making sure they felt comfortable and they knew the audience and kind of what was going to be expected. They have dinner every month. She knows their partners, their kids, acknowledges their birthdays, right? Like things that as a PI, I would never have that level of engagement. And so I have a really close relationship with our patients turned partners too, but it pales in comparison to the time, energy, and effort that Kelly has put in. So very key. And they're an accountability partner. So no, like, WashU, why are you doing that? That's actually not right, and keeping us honest. So power, I've alluded to this, but this is a picture of a grant application that we put in. And it's funny because I felt like the right study design was a randomized trial. And our community partners were like, no, that's unethical because we already know this works. And I was like, no, actually, we don't know that it works. But they felt like that couldn't happen. So we had a debate and we voted on it, and they voted us down. And so we didn't do it. And that's fine. But this was the governance structure. So you see at every level of the power structure, there is a community and an academic PI in charge. And we didn't get the grant. And when we got our summary statement back, they killed us on the study design, despite the page that I wrote explaining why we didn't choose to do a randomized trial. And if I had it to do it again, I would do it exactly the same way, because the relationship is actually more important. Your budget shows your values, and so budget transparency. So I told you, all of our programmatic grants, whenever we can get the money in the community, that's where it goes. And only research grants came through the institution. Also, how do you onboard new partners? So this is, I didn't tell you some of the hardship in this, but in 2020, a lot of our sites, everybody shut down. A lot of the small sites never came back. Like, they could never get the momentum to bring their programs back. So in 2021, the University of Missouri, Kansas City approached us. They had heard about EleVATE, had followed it, really wanted to be involved. And so this is our UMKC team. This is some of the artwork. And then they have a dedicated EleVATE building. So I was so excited. I took a picture of the EleVATE building where they do all of their groups. So also, how do you bring new people in? And also, we have been at the same patients turned partners since 2016. Those EleVATE babies are almost 10 years old now. So also, how do we bring in new patients turned partners in time? Also, what is our protocol to present our shared work? So this is me and Kelly and Rochelle and Sharon, two of our community partners, driving to Springfield, Illinois, to the Illinois PQC to present. But we had to figure out, like, how do we share our narrative and our story? And this is a QR code to a health affairs article. A health affairs reporter came and spent 3 days following people in the collaborative around and told a really beautiful story of what's happened. If you want to see people fight, figure out who gets credit. So co-branding and making sure that you're recognizing the efforts of everyone who is there. And this is another pearl. The race is not given to the swift. So in 2016, my mentors at WashU said, Ebony, you are spending too much time in the community at these meetings. You are on the tenure track. The currency is papers and grants. That's how you need to be spending your time. And they were right. You know, my mentors meant well, but you don't always have to listen to your mentors, because in my heart, it felt like I was in the right place. And so imagine my surprise when my first R01 was for EleVATE. Mind you, we worked together for 4.5 years programmatically before we ever put in our first research grant. And it wasn't until those pilot results that, you know, the steering committee said, okay, we're going to have to reevaluate what we think about research, because there's something special here. We really do need to, you know, so it happened organically. There may have never been a research study, and that would have been okay. So to thine own heart be true. So we are now in the midst of an R01. We are 27 patients away from finishing randomization with that R01. And because of what's happening right now, I got special permission to stop randomizing now, because we did the statistical calculation and we should already be powered to see our primary outcome. So these patients will finish delivering, and then next time I talk to you, I'll have some results. And I wanted to speak briefly about, why does this work, or how does group care work? And this is a really nice paper that was written about, you know, shared medical appointments, or what they're called outside of pregnancy. Like, how does it work? And I want to call your attention to the fact that fully half of the things they list have nothing to do with the patient. It's the clinicians. So I would submit to you that we stumbled upon something that inadvertently group care is working on the clinicians and the healthcare systems, which is why they tend to be effective in certain groups. We also have an R21, because as we started to ponder this clinician question, we were like, well, how's it working? Is it reducing our bias? Or is it making us less racist towards our patients? And it turns out we're not going to change a lifetime of accumulated bias and racism with a little 7-month intervention. But maybe we don't have to. Maybe if, when I see the fact that you took 3 buses and walked 30 minutes to see me today, that your partner is unkind to you, that you have housing insecurity and food insecurity. Maybe when I know all of those things in your life, I show up for you, to care for you with so much more compassion and empathy. And so our R21 is actually looking at, does group care increase clinician empathy and therefore mitigate the impact of racism and bias on patients? So we'll have that soon too. And so the research subject for the R21 are the clinicians. So I'm going to bring it to a quick close now. But this is our timeline, and I showed you the highlights, but I want you to see we start in 2016. In 2017, we get this Missouri Foundation for Health grant that we used to do our curriculum. And then we keep applying for programmatic grants, and we are not getting any of them. So we are broke. We can't make payroll. I dip into my startup funds just to be able to pay our staff. In 2019, we apply for a PCORI. It is not funded. We get a bridge award just to keep us going for another year. In February of 2020, we submit the R01, but then you know what happens in the next month? The whole world shuts down. We once again have a funding gap. We are within 2 weeks of, again, not being able to meet payroll when our R01 gets awarded. And then half of our sites never come back as we're coming out of the pandemic. We get the R21, UMKC joins us. And then in 2024, after 7 years of advocacy, we are able to get Missouri Medicaid to provide an enhanced reimbursement for group prenatal care. And we are finishing up the R01 now. And this is just said in a different way. You see what people get, you don't see what they don't get. So these are all of the things that I applied for that I didn't get, including that PCORI. I had my third daughter January 23rd. PCORI was due February 10th. So the first couple of weeks of her life, my baby's here, my laptop's here, and then we don't get it. And I was so mad. Like, I will never get that time back. But a year later, when an RFA comes that is perfect for EleVATE, I said to my mentor, this is perfect, but I can't put together an R01 in 3 weeks. And he said, yes, you can. Because if you don't, if you wait for the next cycle, then all the people who didn't get it the first time they got comments, they've just strengthened their application. So the competition just gets harder and harder. So you drop everything else you're doing. For the next 3 weeks, you do nothing but that R01. And that is the $4 million grant that we are living on right now. So I'm going to close with the words. It's just a 30-second video of the people who have really made the EleVATE Collaborative happen.
What's different about EleVATE? It offers an approach to overall holistic health for Black and brown birthing people. EleVATE was created by and for Black women. You get all of your prenatal care in a group setting. You also get mental health needs addressed.
We want the environment to be super welcoming.
It has opened me up in so many different ways and turned me more into myself and the baby as well as other mothers.
Being a part of this initiative has helped me and my
to grow stronger. Join. We need you to come join. It gives you hope that things can get better.
I want to leave you with, can I get back to my slides? It's never done that before.
What's different about EleVATE?
Okay, I might just call
it. Offers
I only had a couple of more anyway. Let's see, here we go. So I'm just gonna leave it here. And I encourage you all personally to figure out what is your North Star, because the time last summer I felt like this isn't working. Like, are we making any difference in anyone's life? And Kelly said, Ebony, what are the 3 things that we said we wanted to do? Number 1, I'm not sure, but I think we're making a difference. Number 2, we have enhanced reimbursements. And number 3, everything we've done is in the public domain. So know your North Star and come back to it. My last pearl at the end of the day, the most important thing is your family. You're never going to say, I wish I had written just one more grant. You know, it's the people in your life. And my mom, I opened telling you about her. She passed away during the pandemic. And I was reminded at her funeral that she used to always close her speeches with this quote, and I leave it with you today. Go in search of your people, live with them, learn from them, love them. Start with what they know, build on what they have. But with the best leaders, when the work is done, the task accomplished, the people will say, we have done this ourselves. And I want to acknowledge our funders, the EleVATE Collaborative Patients Turn Partners, my research team who is diligently finishing this at WashU still. We have a YouTube channel, y'all, if you want to hear more about us. And with that, I will open up to questions. Thank you very much. We have 4 minutes for questions. It can be anything. It can be about the work, it can be about life, whatever. All right. Are there any online? Okay. Yes.
So thank you so much for coming and speaking. This was really powerful to hear about what is it like to move from a community where you know you have such impact, you can respond to people, and then go to a different state and hope that you start something similar or something new for you as a person, but also
Thank you. It's a really good question. And I will be honest, it's been really hard. So I honestly, I liked my life and my job in St. Louis. I didn't want to leave. I love the community there. And I am in a 2-career household, and that's really hard. And UNC is the first place that ever recruited both of us. It was like the first time that I moved. So it was the right thing for my family, even though I grieved my career in St. Louis. And as a community engaged researcher, this is another pearl. I wrote tons of grants. There's $6 million of grants in my name, and they are not mine. They belong to the people of St. Louis. So when I moved to North Carolina, I left all of my grants there, right? Which felt like career suicide in some ways, even though it was totally the right thing to do. And I just had to trust that, and I'm a person of faith, right? Like it happened there, it will happen again. It's going to be okay. And that's why I've been really reflective about what are some of the things we did with EleVATE that just felt right, that I would advise anyone who was trying to do this work well to do. The other huge difference is in 2016, I had all the time in the world. Like I was responsible for nobody but Ebony. And now I run a division that has 30 people and I have no time. So I think it's also coming to terms with the fact that this stage of life looks very different. And so I am not going to have an EleVATE story for you from North Carolina because I don't have the time that is required to put in the work, because we still get in knockdown drag out fights with EleVATE, but people trust my heart and intention, and you only get to that level of relationship through the course of time. And so it's going to look different in North Carolina, and that's okay. I submitted an R01 last week. I'm writing another big rural HRSA grant this week, so it will come. It's very uncomfortable in the in between, though. So it's a great question. And the one thing I would say to people who are interested in community engaged research, it is so valuable. It is so worthwhile, but it takes infinitely more time than the person who's doing the pharmaceutical trial, because those relationships don't just come. And do something for yourself in the meantime. If I could go back to the 2018 Ebony, I would have been like, apply for a couple of grants in your own name, so they're portable, so that when you go someplace else, you don't have to leave all of your work behind. And I will say I'm still very, like, EleVATE will never get rid of me, right? I still am very much a part, but also trying to now nurture the next generation who's going to lead that work, as like, it doesn't always have to be you. Like, how do you nurture the people behind you? Mhm. Yes.
Thank you so much for the talk. That's about trainees and early faculty. It's not a lot of people have that, are willing to share those hard parts, and even just seeing your timeline, what it takes to continue to work is very powerful.
Well, thank you for that. I appreciate it. All right. And it is 10 o'clock. So thank you all so much. You all were so worth the trip to the West Coast.